Hello and welcome to this second session of the afternoon. I missed this morning, but I hear it was a fascinating set of panels. We're going to use this session to kind of expand it out a bit more from the UK for a more global perspective. And the clean energy transition, it's not just an opportunity to reduce greenhouse gas emissions, but it's also an opportunity to improve healthcare outcomes. You know, whether that's from solar-powered oxygen delivery for children presenting with pneumonia in Uganda and securing some kind of mortality benefit, or whether that's ensuring more reliable energy supplies for operating theatres around the world. This is a really crucial and interesting aspect of sustainable healthcare. And we've got an amazing set of panelists here today to explore how we might move forward and make change. We're going to have a short presentation from Sivesh, who's going to set the scene a bit about energy security around the world. And then we're also going to launch a new initiative, which you'll all be excited to hear about. And then we'll have a few questions. But perhaps I can just start by going round and asking each panelist to just briefly introduce themselves. Sivesh, if you just want to introduce yourself.
So hi everyone, I'm Sivesh. I'm a surgical trainee and a doctoral fellow at Birmingham with the Global Surgery Unit.
Brilliant. Anil?
Hello again, everyone. Surgeon.
Janet?
Hello, everyone. I'm professor of anesthesia, perioperative medicine, and epidemiology biostatistics, and I'm from Western University in Canada, and I have worked with the Global Surge Unit for the last decade.
Lovely, thank you. And Wale?
I'm Wale Adisa from Ile-Ife, Nigeria, southwest Nigeria, just about 3 hours from Lagos.
Very nice, good. I'm going to hand over to Sivesh for a brief presentation.
So hi everyone, I'll be talking briefly about energy security in health systems globally to set the scene for the next few minutes. So the Director General of WHO have really set out the importance of energy security in health systems globally. It's estimated that about 1 billion people around the world may be impacted by having better energy security. And as you've all heard, energy security is not only important to ensure good sustainable energy, but also to provide safe clinical care. It provides safer surgery, safe maternal health, but also for vaccinations around the world. Currently, the report provided by WHO estimates about $5 billion is needed to provide energy around the world. So, this is just a video of the problem of energy security. So, a sudden disruption of electricity or energy in the middle of an operating theater. So, what we did was to set out what is the need for reliable energy security around the world. So we did a needs assessment, 1,583 respondents around the world from 981 hospitals. 20% of these were district rural hospitals, and we measured how good the energy security is using 28 performance indicators. Our primary measures were the rates of power outages reported, and also the scale of its impact within hospitals, and secondary measures with the number of days affected, change in clinical procedure, and also the impact to patients. So the reported rates of power outages around the world is about 43%, and it increases across high to low income countries. When we look at the scale of impact within hospitals, there is a majority of hospitals in low and middle income countries report the entire hospital is affected when people have these power outages. So the next thing we wanted to find out is, okay, well, there's power outages, but how bad is it in terms of its impact to patients? So within the last 30 days, so within the last month, the median number of days affected from power outages was reported to be about 6 days. And this can be as high as 9 days in low and middle income countries. And patients also do suffer as part of the process. So there's reported effects of delays to procedures, minor and also major complications. So when we think about energy security, it's not only just about providing reliable energy, but also ensuring safer clinical care. And we heard a lot about sort of diesel generators today and about fossil fuels. There is also a high reliance of diesel generators. So in the event there's power outages, a lot of people report high reliance to diesel generators, and these can be as high as 50% in low and middle income countries. So as part of providing reliable energy, there's also a need to think about cleaner energy in the global south. So what are the key conclusions that we can draw from this? So hospital in lower income settings are disproportionately affected by power outages, and they can lead to sort of impacts or limitations to deliver safe clinical care by frontline clinicians. The reliance on diesel generators are certainly very high in these settings, which can cause environmental harm. And with that, I'll pass on to Rob. Thank you.
Thank you, Sivesh. I've brought some very bad news to show that it's not only graphs and figures like Sivesh just showed now, but things can get really bad with power supply to healthcare systems, hospitals in low middle-income countries. The University College Hospital in London came to Nigeria in 1952 and established University College Hospital in Ibadan as the first teaching hospital in Nigeria. Today, that hospital is one of the largest in Nigeria, has 1,000 beds, and does all range of surgical care. But in the month of October, after all the surveys that Sivesh was talking about, 17 days, that hospital was without power. I'm sure some of you can't even imagine it. 17 days. And the only way that bad news ended was that patients and their relations formed what we call in Nigeria an Aluta group. That's a riot. And it went on national news, and then the presidency stepped forward and said, oh, we're going to start paying 50% of the energy charges of hospitals. It hasn't happened from that October till now. It's not only in Nigeria, but in the global south, power cuts to hospitals has a lot of clinical impact, not only on the patient, but on the hospital and the healthcare system generally. And many, many times, we only end up playing the blame game, blaming who is to be blamed, finding what to say about it. It's a very disastrous thing that goes on. And you are a surgeon, you can make noise. And many times, you don't get the solutions. But the solution is not so far from us. It's been shown, demonstrated in very little pockets, here and there, that clean, sustainable energy solution is the way forward. In the few instances where this has been adopted, it's been a game changer for hospitals in low middle-income countries. That's why the initiative of 100 for 100, which is being pioneered from here, is such a celebrated initiative back home for me in Nigeria. My hospital, I'm privileged, is being chosen as a pilot site for the 100 for 100 initiative, where this group is aiming to raise funds to be able to power at least 100 hospitals in the global south. I believe that initiative will be launched today, and I'll be very, very delighted if all of you here will please be a part of that initiative, help to raise these funds, because you're going to be saving a lot of lives, and you're going to be helping the healthcare system in low middle income countries to get better. Thank you very much.
Thanks so much, Wale. That was a great presentation. And it was really nice to sort of have that scene setting and the broad strokes. But Anil, I wonder whether you might fill in some of the detail about the scale of this problem, where in particular is it, and what are some of the solutions that are currently being thought about?
I think the scale of the problem is what our network tells us. And we're really here because people in the room and clinical teams around the world have told us that sustainability is important and they want it to be addressed. And this is part of that process. We've now been told that energy security is a major problem. And as I've gone around speaking to people, it has been one of the things I've had to explain the least hospitals need secure energy. And when I explain that, is for safe surgery, it's for safe childbirth, and it is for safe vaccine delivery. Everyone just gets it. So really, this is what we call an intersection. The primary thrust here is healthcare. It's good, safe healthcare. But it's also the intersection of the environment as well. So the environment twofold. We're both providing secure energy and decarbonising local environments as well through the reduction in the use of diesel generators, reduction on fossil fuels from the grid. So the solutions are, they're different. Our network's telling us they're different to the solutions in this country. So the 100 for 100 project, which this is the formal launch in this country, is aiming to set out to raise $100 million to provide secure energy for 100 big hospitals in the global south. And I just reflect on some of the figures given in the last panel, where we're talking about hospitals in the UK. That's to reach net zero for hundreds of millions of pounds, but that's a slightly different target. We're not aiming to reach net zero for these hospitals. Really, we're aiming to provide secure energy. But so for £1 million for the whole site, suddenly that just puts it into perspective. And what is secure energy? We're learning about that, but it is solar energy and wind where appropriate for daytime care. But it is also about having good quality batteries for nighttime care. It's about doing due diligence and making sure that the companies who we are working with are going to be doing the right things, installing the right future-proof technologies, and we're not going to be stuck with old technology that doesn't work. So that's the solution. Can we really, is there $100 million in the world for this? I think we need to go and find out. I think it's one of those things, people believe in the mission, it feels like the right thing to do. I think we need to raise our first 1 million, then 5 million, and once we have proof of principle, we can scale it. My final point is there's definitely economies of scale in terms of learning. What we're going through with Wally in his hospital, that learning, it's quite hard at times, isn't it? But once we've learnt that, other hospitals around the world will be able to help them so much more efficiently to ask the right questions the first time.
That's so interesting. And Wale, I'd love to bring you in. What are those difficult learning lessons that you're finding? Can you elaborate on those a little bit more?
First is the structure. Are the structure ready to put solar panels? Where do you locate the solar panel? How do you wire it to the building such that it powers what you want? And how do you build, how is it scalable to be able to power? If you're starting from the OR, how do you then connect it to the ICU? So we're trying to start small, but do what can be scaled up and then make it sustainable as well. So the structures are not pre-planned to carry some of these innovations. And so to work with the engineers, to work with the hospital, the design, the initial design, how does this factor in? And then how do you build the future into this? Those are the learning points. We're trying to get it right so that we move up quickly.
So, I mean, the mission is secure energy, and it just happens that secure energy is greener energy for the most part. Janet, where does research fit into all of this? We sort of know what we need to do. What's the research agenda that has to go along beside it, and what's happening at the moment?
Yeah. So I think that's a great question. What does research have to do with this? Well, research, I think, should not be underestimated as a tool for both education, but also for change. And I mean, looking out on the audience, you know, we have a multi-sectoral group here, but each of you knows in your own way that you have colleagues within your particular sector and in sector adjacent areas. And I think that with research, we can actually do something like the 100 for 100 campaign with a research vein that goes forward and actually collects the impacts of installing secure energy in hospitals, and then how does that impact across other things that we care a lot about as healthcare providers, or as politicians, or as energy providers, or as public health specialists. So I just want to maybe bring in an analogy. I think of research simultaneously as implementation simultaneously with not only implementation, but also policy issues. And I tend to think of all of that on a global scale, because anything that we are going to do anymore that's going to have large impact needs to be globally joined up. When we think about sustainable healthcare and sustainability in general, and if we're going to do it globally, we have enough power to show impacts on things that matter, including healthcare, health outcomes, but not only health outcomes, also social outcomes and economic outcomes. So the analogy I was going to bring up is the Rubik's Cube, whereby if you're solving a Rubik's Cube, you don't just try to solve one side at a time. You're solving it simultaneously, sort of all at once. So when I move the Rubik's Cube, I'm not only solving for one side, I'm solving for things simultaneously. And I think a lot of our colleagues in the clinical world think that if we move on to energy, we'll stay in your lane because it's going to be competitive with what we're doing clinically, and it's not. It's actually, there's co-benefits, there's synergies. We're solving for it all at once. So the Rubik's Cube, I think, is something we can think of, and research is a big part of solving for things simultaneously and showing that it actually is making a difference. And if it's not, then we need to be willing to look at that and solve again. So that's how I think research fits in with this, big, global, and with policy and implementation simultaneously.
Thanks, Janet. And we published a great trial earlier this year that I'm sure you'll all be familiar about oxygen delivery to children who were presenting with pneumonia in Uganda. And this was more than 2,400 children presenting with pneumonia to different hospitals in Uganda. It was a cluster randomized control trial. And they put solar-powered oxygen delivery units from concentrators in each hospital. And that secured a huge mortality benefit. And the number needed to treat for that was 45 to save one life. So the cost of each unit was $12,800. So let's talk a bit more about costs. And we've got this 100 million. Savesh, maybe I can bring you and Anil in here from some of the survey work that you've been doing. There's obviously the will. You've talked about how this is something you've heard again and again from clinicians. Is there the will financially for that investment? Is there the money?
I think there's certainly huge benefits from gaining from that. I guess the question is, how do we measure that impact to make it more meaningful? So, for instance, that trial that you've highlighted has got significant benefits to patients, to kids. So I think it's also understanding how we measure what we implement, because there's obviously an upfront benefit of, upfront cost of putting solar panels up. But how do you measure the returns? Do you measure it over a year? Do you measure it over 5 years? Do you measure it over 10 years? And what is the return to society and economy as a result of that? I don't think we have answers to how we can do that best. So I guess that's part of the future.
Anil?
Yeah, and my take is that there are groups around the world, quite rightly, who have installed solar power into operating theatres before, individual operating theatres, mobile operating theatres, and we're communicating with them to learn from their processes as well. And there are groups who have done, as you described, and yeah, that's an amazing trial, and it's really nicely conducted and reported, and we should learn about the evaluation. I think if we set out to raise this, if I said it was, £100 million for 1,000 operating theatres, I'm not sure we'd get there. I don't think the world going forward wants to see these individual disease threads anymore. So I think what's different here is we're now beginning to talk about whole hospital resilience. And we all learnt about that through COVID. And I'm sure we all had our own journeys through COVID in healthcare. And we did the COVID Surge project. And coming out of that, we learnt about resilient hospitals. So it's the same message about how surgery is going to fit into global health in the future. It's going to have to integrate into care pathways. I think, and it's a gamble, and this is a high-risk project. It might fail. We might be sitting here in a year's time and say we've made no progress. We might have made progress. I don't know, but I think we're willing to try. My feeling is that the way to do it is to integrate it into the hospital, to say that we'll start with surgery as this little pilot site for £50,000, and then we'll very rapidly plan and scale the rest of the hospital. And suddenly when I say that, and I talk about the paediatric wards, and I talk about the other areas of the hospital that are going to have benefit, people just nod and go, yeah, okay, that makes sense. Off you go. everyone's waiting for the first mover now. So that's our next step, isn't it? We've got to be the first mover, get the pilot site done and evaluated. And that's the other thing I'm learning about all this money in the world. If people are going to invest money now, they want to know what the impact is. They want to know what the evaluation is. It's not enough to say we've installed solar panels, here's a photograph. They want to know a year later, has their money been used sensibly?
Yeah. And what's been the savings? Because there is huge savings for clean energy for hospitals. Why do we think that the operating team and the theatre setting is particularly a sort of useful space for change in this area? Wale, maybe I can get your perspective on this.
The operating room in a major hospital consumes a lot of energy. And in my hospital, I sat in front of the medical director one day, and I was talking to him about this project. And he looked at me and said, do you know the cost of diesel powering the operating theater? For a pediatric surgeon that is shouting, I have a child with obstructed hernia, when the hospital puts on diesel, the cost of powering that theater for 4 hours is exactly 5 times the amount that that patient will pay. And for him, health economics in front of him is like, oh, we're going to spend so if we have this sustainable green energy for the OR first. In my hospital, the theater consumes like 40% of what the whole hospital consumes. So if we target the operating room first, a lot of clinical impact comes from that. But for the hospital itself, a lot of cost saving also comes from targeting the OR. Of course, we know that every other aspect of the hospital, the lab, we also work for you to be able to get into the OR. But I think in isolation, that stands out as first point to target.
And we heard in the session earlier Hugh's statement that, within 18 months, if Birmingham had done something, that would sort of spread across the land in the UK. How are we learning about sharing knowledge globally, and what are the timescales on that knowledge sharing? Janet, maybe you could start, and then Anil, if I could bring you in afterwards.
Again, a great question. So communication is key, not only to engage, I think, buy-in, but also with clear communication. I think that a lot more people will be sort of caught up with the message and want to be part of it, because it is a globally joined up collaboration that will make the difference sooner, faster. But with that communication comes some risk. And we're talking about communicating an important message that's multifaceted, that needs itself to have, certain taglines that are catchy but that are not overstated. And we also need to be sure that messages travel across cultures equally so that that buy-in can happen. We also need to be entirely crystal clear what we're doing here and what the intentions are, because as soon as there's a breach of trust through opacity in our communication, if there's a breach in trust, if there's fear of different motivations, then we've lost the game. So I think treading forward with communication that is clear and where we have all joined up on equal footing, our global colleagues in all spaces, because we're not all starting on equal footing. And I think that the global surgery unit and our the hub and spoke model is a really great network to start the momentum through, but also to show that we can all be on equal footing and move forward with this issue of sustainable power.
Thanks, Janet. Anil?
I think my shared learning point is there's this thing about health and energy together that is very emotive for people. I think there's this thing about surgeon in the operating theatre that's emotive, but even more broadly for a community, this health and energy thing. So when I look at the panel that was just on, and we're really talking about, health and education, we're talking about health and education together. That's a very appealing story. And for the people of Birmingham, the West Midlands, suddenly seeing that its 2 biggest campuses on health and education coming together just makes sense to people. And the story we're getting from some of our sites globally, for example, one of our other pilot sites is the opposite. It's a small 60-bedded hospital in rural India who have completely different challenges and needs. But what their ambition to get there, if we can get there, the ambition, the vision, is that they will also bolt a telecommunication mast to the side of the hospital that's linked to the energy array. They'll be able to link in a clean filtration, water filtration unit. And ideally, if they can produce enough energy, it can then filter out into the small local community around them, which includes a small school. So that concept of we're stepping way out of the operating theatre now and bringing health and education together is very appealing. And why are we talking about this? I think as researchers we can evaluate it. We've spoken about that. I think as surgeons, we tend to be relatively permanent fixtures in the hospital. And so we have a very clear need for reliable electricity. So we're really the voice of the patient in that. We can say we need this, and we can get ourselves into the right offices to have those discussions. I think that's why we're here.
That's great. There was a great question in the sort of chat, which I think has gone, but it's about resiliency and whether some of this project sort of accounts for climate adaptation. And how we can have energy resilience and that can be improved in the context of flooding. We know the number of hospitals in the UK alone, there's a huge percentage that are very vulnerable to flooding. We sort of extrapolate globally that there's a huge problem there. Anil, do you want to answer that one?
Yeah, I think hospitals in lower income countries, the global south, they are national critical infrastructure, and they are not seen as that. They're often seen as buildings where healthcare takes place, and they're slightly isolated, but they are critical infrastructure for countries and communities. And I think that I see groups like the Gates Foundation and others funding very narrow diseases. And actually, I haven't seen anyone brave enough to fund the resilience of a whole hospital. But I could think of very little more important than that. So yeah, making hospitals, surgery, healthcare hospitals more resilient to climate changes in both extremes, flooding and heat waves. We were talking about your air conditioning units in your hospital and how the power demand from those is so high because they're old. And the draw of that from the grid is so high, or from your local energy supply. So in a heat wave, the draw becomes even bigger. So it's all interlinked. So I'm very keen not to take a single solution and just look at the operating theatre here. I think this needs to be this whole hospital solution. And I think we've also got some work to do with research funders to persuade them into how important this critical infrastructure is. But feeding back into resilience, preparedness, those seem to be the right language to be using at the moment.
That's right, and it's difficult to make arguments for things that aren't just vertical and have that horizontal approach, as you say. So this is a great start. I think we'll probably end there in the interest of time, but thank you so much to our panelists and for a really fantastic discussion.
Perfect. You're so welcome to our pre-coffee fireside chat and thinking about things from different perspectives between primary and secondary care. So on our panel today we have Vicky. Would you like to introduce yourself, Vicky?
I'm Vicky Marshman. I work at UHB. I'm a manager in the NHS, and we're in pantomime season, aren't we? So we can have a boo, I suppose, as well. But I'm a manager in the NHS. I am sustainability lead at UHB, and I'm one part of a very small but perfectly formed team over there that deliver across sort of energy waste, different sustainability streams at the Trust.
And Vicky, you've been working on our energy programme and the UK-facing research programme.
That's absolutely right, and particularly looking at the waste streams coming out of theatres, and I know more about the different colours of bags and the processes that go into waste than perhaps I ever thought I would do, but thoroughly enjoying it.
A lot more than surgeons, that's for sure.
Okay.
And Katrina.
Hi, I'm Katrina Davis. I'm a GP in Solihull. I'm also a Greener NHS regional primary care support lead as of a couple of weeks ago. But most of my time is spent as a director of Greener Practice, which is a network across the UK of GPs and primary care staff who are interested in sustainable healthcare.
Wonderful. So perhaps starting with you, Katrina. So from a primary care perspective, why do you think it's important to be having these discussions today?
Well, I think, first of all, a fireside chat I don't think is quite the right thing for us to be talking about in the midst of an energy crisis with fossil fuels. But anyway, the point in primary care is that general practice sees about 90% of patients, of the population rather, every year. And so we are very well placed to be able to start making the changes through the sustainable healthcare principles of prevention and health creation, self-care, leaner processes and reduced waste, and alternatives, lower carbon alternatives. So we're in a great position to do that, but of course time and resource, as with everybody, is very short on the ground. And so for us to be able to show that this is not an extra, but actually good patient care. Everything we're talking about today is just good patient care. And if we can get good patient care, which is also going to reduce inequalities, because of course, much of the time, the things that we talk about that are related to climate, health, and nature, that triad, which are very much intricately linked, is also having an impact on health inequalities. So anything that we can do to make a difference to one will make a difference to another, which also feeds into why primary care is so important to be doing this.
And in primary care, you're so close to the community. Are patients and the public asking for this and asking for us to get better?
I think we're all patients, aren't we? And we've often, well, many of us have had relatives who've been in hospital or who have gone into care homes or who've died. And we've discovered huge bags of medication that was never used or which was not used properly or which was unwanted. And you find that chemists will receive these big bags of wasted medication. The patients hate waste. They absolutely hate wasted medication. Of course, with that medication is all of the power that's taken to create it, the power that's needed, or the transport, the packaging, the metabolites. At the end of the day, we're peeing and pooing out of all of this stuff and all the danger, the damage that it's doing to our waterways. So there are so many things which patients see that when they see waste and they know that they can't return these things to be the medication to be used again, particularly in general practice where 60% at least of general practice carbon footprint is medications. And so, you know, we need to start thinking about different ways to avoid using those medications in the first place. And that's where social prescribing, for example, green prescribing, and physical activity and all the things we know which are good alternatives to medication need to be more readily available.
Wow, that's staggering. And my father-in-law has a whole cupboard full of diclofenac gel, which has been nice for my shoulder recently, but yeah, certainly a lot of waste. How about you, Vicky? So from a secondary care perspective, why do you think it's important to be having this conversation today?
And I think to echo some of the points that have been made already today is that and this is the Rubik's Cube, there you go, I'm going to look into the audience, but the Rubik's Cube example as well, is that we know in terms of sustainable solutions that often they both address health inequalities, we've spoken about that briefly, but also in terms of some of the challenges we face, particularly at the moment. So, you know, if our chief finance officer were here at the moment, he's got a little bit of hair left, but it's a massive challenge, and we all know just how tight things are financially in the NHS, both across sort of primary and the acute sector, but I think particularly at the moment felt in the acute sector, and just how busy hospitals are as well. So if we're in a position where we can introduce more sustainable solutions, which also save us money, then we start to address the financial challenges. But we're also looking to make sure that, frankly, that the population is healthier, that we can support people to be healthier, and therefore there are fewer people needing secondary care, and having a better quality of life as well. And it is that point that it's not an additional piece, and that's often what it can feel like. It's sort of and sustainability or and health inequalities. And I think over the past sort of 5-8 years in the NHS, we've got much better, definitely in the inequalities space, at understanding it isn't an add-on, it is absolutely core to what we do. And having more coming together like this, more conferences like this, and understanding that sustainability isn't an add-on, it's something that's absolutely central to what we do. And if we crack crack this, we can crack an awful lot of the other challenges we face, I think is vitally important, and why today is so important.
And when you're in high-level executive meetings and planning meetings, do you feel like you have a strong voice in that room? Do people prioritise sustainability?
I think it's a mixed bag at the moment, if I'm being completely honest. It depends on the room, it depends on the purpose of the conversation, and I think that's part of, we've spoken about leadership quite a lot today. You know, part of a leader's job is to understand what message is going to land well in the room that you're in, and how, frankly, you bring sustainability into that. That is part of our role, and I think that's something that it's not particularly difficult to do because it does speak to many other agendas, but there is an obligation on us to do it when we can and to make sure that it's front and centre of what we're doing moving forward.
Of course, in secondary care, slightly further away from that community voice, perhaps, but do you think patients think this is important? Do you get it fed back through patient panels and things?
Not unprompted, but when we've asked the question directly, what we've had from patients tell us is that, frankly, that it's something they expect hospitals to be doing. They think we have a responsibility in this area. But one of the things I was looking at sort of fairly recently was with the consultation the government has launched on Change NHS, where we were all able to offer suggestions about what the NHS should do to move the 3 shifts the Secretary of State and the Department of Health and Social Care has identified. In the top 10 of those are 2 that speak to sustainability, one of which much more focused on waste, so why can't we recycle crutches and boots and that kind of thing, and that has more than 1,000 sort of thumbs up on it, and another one on solar panels on hospitals, and that's just shy of 1,000 thumbs up on it. So while anecdotal, I think what is very clear is the public more broadly and patients don't like waste, want to think about how we can be more efficient and use our pounds better, and in that there's a significant green thread as well.
Wow, fantastic. And perhaps going back to primary care then, so where are the big impact areas, you think, in the next 10 years?
Well, medication is the main one in primary care, and pathways, so avoiding duplication of testing, avoiding testing if it's not needed in the first place, but really trying to keep people healthy, as you've just said. So health creation is the big thing that we should be focusing on, and actually it's one of the things that Lord Darcy's most recent report came out saying as well. And if we give an example of, I mean, at the moment in Greener Practice, which is this network across the country of GPs, we have a number of different WhatsApp groups which have hundreds of different GPs and clinical pharmacists, nursing staff, managers, secondary care people, who are all interested in different ways that we can sort of cross-pollinate different ideas. At the moment we're launching or due to launch with some SBRI funding, a clinical platform which has got off-the-shelf, free-to-use projects which are all researched so that somebody can just say, right, what is it I want to do? I'm going to search which type I'm after, whether it's to save money, whether it's to have a nature focus, whether it's for staff morale as well as patient morale, patient care. And then they can, practices can choose what they would like to focus on, which also gives what the CQC, because of course the CQC is looking at sustainability as well now, so they have that as well as the case studies and ability to contact people who've done the case studies. So we're talking about how to do it. Everybody wants to do something, but they don't necessarily know where to start, and it's got to be made easy for people. So this is what our platform's trying to do. There's also something called the Green Impact for Health Toolkit, which has 100 different steps that GP practices can take, and they can get bronze, silver, gold, platinum awards. So there are lots of different things out there to be able to use to change the way that we practice, and really it is all about that change. When I first started doing this about 4 years ago, I was watching the launch of the Greener NHS, and I just had this sudden light bulb moment that, you know, we're not going to have a vaccine for climate change that we had coming up for COVID, and I started asking around Birmingham and Solihull. there was nothing happening. There was nobody else. I was the weird green one that was looking to find out how we could do anything differently. And so to be seeing how much this has proliferated over time is really exciting. I think the fact that this is going to carry on proliferating is very good reason for hope. I think we need to be optimistic that things will change, because we've all got this hope that we can make a difference.
Definitely, and I love the holistic approach, wrapping in wellness and well-being as well. So Vicky, thinking about in secondary care, I guess you can take a really wide lens. It's such a complex system. What do you think are the big high-impact areas in secondary care for the next decade?
And we've spoken quite a lot about decarbonisation of buildings, and I mean that's where you're going to have the most significant impact. But I think there are sort of along the patient pathway and sort of journey through secondary care, and particularly through our sites, there are plenty of opportunities. How people get to us when they need to come onto sites, you know, I think anybody with experience of most hospitals, particularly in England, will have perhaps driven around a car park more than once to try and find a parking space. You know, most people, and particularly for us at UHB, come to our sites by car. That's about working with other system partners, whether it be National Express for the buses, who have been incredibly supportive at offering heavily discount bus passes for patients and for visitors as well, and seen reasonable take-up of that, or with the train companies, all thinking with more innovative ways that, frankly, people don't necessarily need to come on site to have their consultation as well. And obviously that, again, something that got picked up in COVID, and we need to work through what works there, make sure we're not exacerbating any inequalities as well. But when it is something that's suitable for a patient, we think about that. Quite a lot of work from colleagues has gone on in the space of food and patient meals as well. At the moment, working to have meat substitutes put into a lot of our minced dishes, so there'll be less meat in them, more substitutes put in there as well, and with very positive feedback from patients as well. But there's something in the next couple of years, but definitely in the next decade, about being a bit braver as to what we as a health service can do in terms of what we're providing in food, and taking a leadership role as well in that. Not necessarily something that will land well perhaps with all of the news media in this country, but that's something that, you know, if we do have a leadership role and we have a voice to be heard, there is a need to be brave. And then real questions. We've spoken today about gas, we've spoken about medication, and there are so many opportunities that are there, but it's really thinking holistically and thinking about the workforce as well. We are a massive workforce, the NHS workforce in this country, in England. So what can we do to make sure that we're supporting green practices for our staff as well?
Such a broad perspective. We were talking earlier about limiting perspective for health technology assessment just to complications and the carbon effects of that, but it's such a broad lens to take on. So if I could pin you down for something that you want more of from primary care in the coming years, what do you think is the role for better integration across secondary and primary care?
Well, I think we know we do it better when we do it together. And I think, you know, we're both here today, and clearly there is an open dialogue. And the ICBs as well, which have got a couple of mentions today, give an opportunity for us to come around the table, but in quite a structured and formal way. I think the more we can do together and the more conversations we can have, particularly when we're thinking inpatient pathways, when local GP practices who are perhaps referring into the local hospital, you know, what does that look like in terms of working together and making sure that's working for patients. And I think the other point we've touched on today is that we know our colleagues in primary care have a voice in the community and a sort of in and of the community in a way that secondary care acute hospitals aren't quite as much. So in terms of being that voice that's listened to and able to bring patients, citizens, our communities with us, I think massive opportunity there, and really keen to work together.
Wow, fantastic. It sounds like you've got an open book. What do you want more of from secondary care?
Well, second, you've got a lot of power in your trusts, so to be able to have that power to make the bold changes that we can't necessarily do in primary care, having not so much power, and so especially changing the culture so that this is the norm, so that what we're doing, we shouldn't need to have another green surgery conference in 5-7 years time, because it should all be the norm. It should be what we're doing. So anything that secondary care can do to have collaboration with third sector as well, and I'm thinking particularly about you know, maybe there are ways, we know that there's a lot of evidence, and we haven't mentioned nature much today, but there's a lot of evidence that if somebody's lying in a hospital bed and they're staring at a wall, they're going to recover more slowly than if they're looking at nature or looking at green space. And there are very many ways that we can think about nature, and that might be something which secondary care could maybe think about. We know that the wildlife trusts have came out with a very interesting paper last year showing the large amount of money, about £650 million, which could be saved by the NHS through patients having nature-based solutions. So they're just thinking about how we can use that in our trusts, as well as maybe thinking about green prescribing in some way as prehab, for example, or those sorts of things.
So that's really slipping into the world of public health, isn't it, really? So perhaps next year we should have primary care, secondary care, and put some of our public health representatives and things as well. We've got about 5 minutes left, so I'm just going to pin you down for one more thing and then perhaps have a question from the audience. So for each of you, we're in the season for New Year's resolutions. So perhaps, Vicky, first, what would you like to achieve before Christmas? What's the big plan for next year? And then what's the five-year vision? What's the big change that needs to happen?
Okay. So before Christmas, and we really are getting tight now, aren't we, with that, so we're just over a week. One of the things that struck me over the past sort of 4 weeks or so is my father-in-law has been in and out of hospital, and I've sort of been dealing with that and social care in a different part of the country. And I guess we've spoken a lot about our professional roles, and that's why we're here today. But in our personal lives, we are all citizens, families, friends, whatever it might be. And I, genuinely hope that most of you have no interactions with the health service before Christmas or in the sort of immediate period afterwards. But what I realised is how much action I could take to support him that perhaps that is greener. So whether that is taking clothes in for him so he's not in a gown, and my AHP colleagues would say that is the right thing to do as well in terms of his recovery and how he is heading. Thinking about how we are getting to that hospital, I'm not saying we've completely cracked that, we're driving at the moment, but there's ways through it as well. And thinking about understanding what medication he has got at the care home, talking to them, so making sure we're not leaving with drugs that frankly he's already got there and we're just sort of piling them up. And it made me realise how many sort of small interventions I can take that can make a difference. So I guess there's that bit there. I think in the medium term, and I would say to the audience, and we've got a question about how to sort of better engage with different teams. I think by and large, if you pop your head over the parapet and put your hand up and say, this is something I'm interested in at your trust, then there'll normally be somebody that's really keen to hear that. So I would say sort of if you want to be a champion, you'll probably be pushing at an open door if you've got an idea or you want to get involved. So I'd say do that. And in the longer term, and it's come up a couple of times today, I think there is that bit about there's a lot of plates spinning. I mean, it's a statement of the obvious, isn't it, in the NHS, but there's a lot of plates spinning and we all try and keep them going, and sometimes one falls down. And sustainability at the moment is one of them that often falls down. And I think that sort of tenacity and commitment to pick it back up and keep going is what will get us to the point where it is absolutely embedded, and in the nicest possible way, we don't have to be having this conversation in 5 years' time.
Hopefully still the meeting, but...
Meeting great, but different aims.
Wonderful. It's great to have some actionables. And for you, Katrina?
I think, well, what I'm due to do is change my bank. I think this is something which we all need to look at. This reiterating what was mentioned earlier on about acting as role models and the 7 different things that we can be doing. So financially, that's something we can all be looking at. And if you look at Switch It Green, that's a website where you can just see how bad your bank is or not, and decide whether you want to change it. And talking about it, we can all talk to people about having been here today and just finding out who else is interested. And once you've got another buddy in your team or in your department, then saying, right, okay, well, how can we make this fun? Because, people... The thing that's really exciting in general practice, any chats that you have in or WhatsApps or whatever in general practice are generally very demoralised and people are pretty down. Whereas in this space, it's just really exciting. You know, there's a lot to be done, and people coming together, staff morale definitely gets boosted if you do things together that you know is to a greater cause, and most people want to do something along these lines. So I would encourage more discussion with whoever you can find who's also interested.
That's marvellous. Well, that's a perfect way to bring the session to a close. I feel positively inspired. Thank you both for joining us for Fireside Chat.